I want to do a couple of things. Um, and just to put out an introduction real quickly. I started out at Capella as a faculty member in the addiction counseling program and worked there from 2009 to 2013. In 2013, I came over to the MFT program. So, um, in addition to being a core faculty member with Capella, I'm also the clinical director at Sundown Ranch, which is a adolescent treatment center in Canton, Texas. So, and interestingly enough, what has happened there is that most of our clients have now been disclosing histories, recent and remote histories of traumatization. So, in addition to trying to work on just the skills needed to get into recovery, we're having to also work on skills related to trauma. So, I'm going to put up a PowerPoint in a moment that I worked with in developing for the Mental Health America presentation this past February. Co-presenter was Samantha Goss, and I've amended the PowerPoint to shorten it a little bit. There were 31 slides. I don't think we have time to get through 31 slides and still do some discussion. So here we go. We'll go ahead and pull that up. There we go. Well, I have to reduce that for a second. Let me share my screen. There we are. And so I'm going to reduce this a little bit. Well, maybe I can, maybe I can't. Okay, so start off with just some issues about chemical dependency basics. This is going to sound like heresy to say this, but when you read research documents and material written by academicians, you need to read them with caution. Because as academicians, we talk to each other, we share with each other, we go back and forth with each other, but we typically don't get too far outside of our own bubble. So academicians tend to not make a distinction between abuse, dependency, and addiction in most of their writings. So it's almost as if everything fits the same category. But there is a distinct difference between abuse, addiction, and abuse, dependency, and addiction. As Doug Talbot, the former medical director of the Physicians and Surgeons program in Smyrna, Georgia, said one time, there's a difference between the alcoholic who hugs the bottle versus the alcoholic who crawls into the bottle. And quite often what we find is that people who are dependent on a chemical but not addicted will actually possibly in certain circumstances use a chemical to a greater degree for a period of time than the person who's actually addicted. However, when they decide that they want to stop, they stop or they moderate, and they stop and moderate successfully. An addict is not going to stop and moderate successfully, at least not generally. Usually what happens is that when addiction occurs, there are structural changes in the brain, particularly in the limbic system, the hypothalamus, and nucleus accumbens, and the medial forebrain bundle. So addiction actually can be looked at as an acquired appetitive instinct. And by definition, an instinct is a drive that's resistant to cortical control. The French have a proverb that a starving man will eat poison if it's tastefully prepared. And that's been demonstrated in sadistic prisoner of war camps. People will play all kinds of games with themselves just to eat something that they've been told will kill them. So it's important to consider that actually the process of recovery from addiction is synonymous with the hero's journey of overcoming. And that's what narrative therapy actually is about, is a hero's journey of overcoming. We also have been able to ascertain initially through a lot of the work by Donald Goodwin back in the late 50s and early 60s when he conducted blind adoption studies and looked at the looked at the chemical use or alcohol use in particular of children who were adopted at birth, and found that the alcohol use patterns of their adopted family had very little impact on their eventual alcohol use. What had the most impact was the alcohol use of their biological parents who they never met. So what came out of that, and this was done through several countries, but what came out of that was that if one parent is alcoholic, 35% of their children will be alcoholic. If both parents are alcoholic, over 60% of their children will be alcoholic. Now, if we look at concordance rates of drinking among siblings who are adopted out at birth, and the siblings who never meet each other and don't know each other, their drinking patterns match about 12% of the time. When we look at fraternal twins who aren't identical but share the same prenatal experience, their drinking patterns match about 22% of the time. Identical twins, and we could argue the fact that identical twins are not really two people. They're zygotes or clones of the same person because they share exactly the same genetic material. But identical twins' drinking patterns match over 60% of the time, even if they never met each other. Also, a lot of their behavioral characteristics match in the same way. So it's important to understand that when we're looking at addiction, we're looking at a different animal than chemical dependency or chemical abuse or chemical misuse. Once someone becomes addicted and they stop, usually the most prevalent symptom of addiction is post-abstinence craving and preoccupation. They find that they think about it all the time. They can't get away from it. They dream about it. They ruminate about it. They struggle with it. They hurt in the absence of the chemical. The greatest period of relapse for addicts is the first 90 days. Interestingly enough, the second greatest period of relapse for addicts is the next 90 days. Once someone has been sober for 6 months, there's a good chance they'll still be sober at a year. But the 3-month point and the 6-month point are incredibly critical in terms of adjustment. And a lot of that has to do with brain recovery, just to put it real simply. The post-abstinence withdrawal syndrome has been well documented since the early 70s. E.M. Brecker in the book Illicit and Illicit Drugs documented it. John Largent at the Texas Research Institute of Mental Sciences in 1979 was able to document that in terms of an actual research study involving addicts and outpatient recovery. But the post-abstinence withdrawal syndrome is characterized by increases in norepinephrine, irritability, restlessness, and craving. These things go up as a package deal. They go up as a package deal, they go down as a package deal. So one of the things to think about with this, and what I'm advocating, is that when we talk about addiction treatment, we're really talking about medical family therapy. This is the same approach in a lot of ways that we would consider if we're dealing with chronic kidney disease or diabetes or emphysema or heart disease. So it's important to take the phrase disease concept and dispose of that. It's not a concept, it's a model. The disease model has to do with the alterations in the neurochemistry and the neurological structure of the addict, so that they now have a new instinct, and that instinct is to use any chemical they can get their hands on. I know that sounds extreme, but basically, folks, I'm sorry, I'm moving this around. Basically, I've treated over 5,000 addicts in my time, and I have yet to meet an addict who deviated from that pattern. So we think that there's basically 3 doorways into addiction. Genetic predisposition, probably 60 to 70%. Emotional or physical trauma causes a vulnerability to chemical dependency by shaking up the brain chemistry. So people who aren't necessarily vulnerable now become vulnerable. what's interesting also is a lot of people who've experienced physical or emotional or sexual trauma come out of families of addiction because one of their parents or their relatives have been active addicts who were unfortunately acting things out under the influence of chemicals. So you get a good correlation between addictive families and trauma, which leads unfortunately, a lot of academicians to say that trauma causes addiction. Trauma does not cause addiction. Trauma opens the door for addiction. There's a correlation, but we need to get away from the causal idea that if someone's an addict, they must have had trauma at some point. It could be that they did, and it's likely that a lot of addicts have had trauma. But we want to get away from the idea that there's a causal relationship between trauma and addiction, or a causal relationship between addiction and trauma. There's a strong correlation. They do occur concurrently quite often, but again, as social scientists, we make a distinction between correlation and causality. However, when we look at clients, especially adolescents who are in addiction treatment and they've had physical or sexual trauma, we find that they use a wider range of chemicals, they use them more intensely, and their recovery process is much slower. And so that is part of what happens a lot of times with the combination of these two. We also find that when people want to go in and talk about the details of the trauma too early, they actually re-traumatize the client. So it's really important to consider going slowly and letting the client set the pace for what you're looking into. So this is a drawing by one of our clients at Sundown Ranch, basically trying to illustrate the different things that contribute to the anxiety that elevates the norepinephrine and craving and irritability and restlessness. So it's also important to consider resilience. And not everyone who experiences trauma and not everyone who experiences addiction is going to require the same type of treatment to get through it. There's a lot of resiliency on the part of both elements of this process. This was also done by one of our clients who had been traumatized and was trying to move into recovery. And she really needed a therapist who was able to sit down and be patient with her. And it did happen. She had a good therapist who worked with her. It wasn't me, by the way. One of the things to think about with this is also the role that hypnosis plays in terms of the development of narrative therapy. The third comment is significance of expectation that believing is seeing. We get that from Heinz von Forster, who made the comment that seeing isn't necessarily believing. Actually, we only see what we believe we're going to see. So if we believe that addiction is impossible to work with, we're going to see all the evidence to support that. If, on the other hand, we believe that recovery is possible, we're going to find the evidence to support that as well. One of my supervisees was working with a client on a situation similar to this, and she said every time I try to go into positive futurization with a client, they can't make that step. I said, well, how are you phrasing that? And I said, what if we talk about doing some artwork and some journal work to develop an identity of the person who is in recovery 6 months from now? What does that person look like? What do they act like? Who are their friends? What are they doing in school? And she said, well, George, I'm no good at that. Well, why not? Well, I don't think I'd rather think about what they need to do now and not get into this imagination stuff. Well, she used the term BS, but yeah, about a possible future self. So she doesn't believe it, so she's not going to see it. So part of what I'm having to do in supervision with her is to help her come to terms with how can you believe something that you haven't experienced before yourself. So the other thing to think about is our choice of vocabulary. if you use phrases like pain, uh, or you talk about your depression or your anxiety or your addiction, what you're doing is possibly concretizing that and anchoring that within the client. It's a lot more helpful to talk about the addiction or the problem or the difficulties that you're overcoming, and to constantly phrase that in a more hopeful way. Um, Now, I have something here about the yes set, but the yes set is simply if you can get the client to respond favorably to at least 3 points or 3 questions, then your chance of getting a favorable response in the fourth one is phenomenally higher. That was talked about or written about by Bill O'Hanlon based on his work with Milton Erickson. The yes set is really an exaggerated packaging question. Um, so I had the opportunity in Galveston, Texas, several years ago, to at TAMFT to sit through 3 days of Michael White. It was his last presentation before he passed away. But he talked about two things that really stuck with me in a big way. One of them was the most important characteristic of a narrative therapist is unrelenting optimism. Unrelenting optimism. He said the big task of a narrative therapist is to externalize a problem and internalize a solution. He said clients always want to do the opposite. So how do you explain that you're doing so well? Well, it's because you're a great therapist, or you're really working with me well. Well, that's actually externalizing the solution. So the follow-up questions are going to be something like, but how do you explain that you've taken advantage of what's been offered to you? What does it mean about you that you've taken advantage of what's offered to you to deal with the problem in this way? Not your problem, but the problem. That's the simplest way to externalize a problem, guys, is just to use the word the as opposed to the word you. Um, questions, much more helpful than statements. So this same client, she had a lot of difficulties in terms of her relationship with her parents. And a lot of it had to do with parents who didn't believe what she had to say. And they minimized the impact of what she'd been through in the struggle to move into recovery. So thinking about, in terms of narrative therapy, that as you guys all know, dominant stories are composed of absorbed messages from early and recent experiences. This is a lot like object relations or the core beliefs in rational emotive behavior therapy or cognitive behavior therapy. Most of the messages that we live by, or I should say, most of the messages that our clients live by, are so old that they're not really entirely conscious. So we want to get an idea about what did this message when did this message start to take effect? How did it manage you? In this case, the message would be the messages about addiction, or the messages about trauma, or the messages about anxiety or depression. So when did these messages, or when did this problem start to have an influence, and how did it change your story, or how did it change your path? A lot of people, most of the writing in narrative therapy is about stories. I'm much more visual in terms of my orientation. I think much more about paths. And so it's important to get an idea about, is your client more focused on auditory issues or more focused on visual cues? So thinking in terms of a path or a story, depending on the orientation of the client. And then looking at unique occurrences, which is narrative therapy's term for exceptions, or unique outcomes when they did something different and it produced a different result for them. And then unique account questions. What does that mean about you, that you're able to, despite the influence of the problem, you're able to put this together and do this in this way and get this result? And as you continue to accomplish this, what new changes is this going to bring about? You know, when I'm talking about what might happen in the future, I don't use the word if. That opens the door for possible negation on the part of the client. I just assume that the changes are going to continue. So as you continue with these changes, what new changes are these changes going to bring about? What new avenues do you think you might explore as you continue with this and as you continue thinking like this and looking through this and talking like this? And deconstructing the message of the problem. So let's talk more about when the problem wasn't effective and when the problem wasn't very helpful. So looking at how a lot of this seems to work. Once someone develops a problem such as addiction or trauma or both, they're going to run into activating trigger events. The trigger events are going to interact with the restraining messages of the problem, which create emotions, which then trigger actions. And basically, folks, just think about this. We don't really do much of anything without an emotion behind it. You know, if you're talking to a man's going to say, "I don't act on emotions, I act on principles." So your next question is, so what does it feel like when your principles aren't followed? So there you go. You get to the emotion in that way. But this is a cycle. It's not a straight line. This is how a dominant problem asserts itself, maintains itself, but it's also how exceptions or unique occurrences assert themselves and maintain themselves. So it's so important to look at how this cycle continues to work in a positive way for the client. So in this case, the client is trying to establish some type of a different lifestyle, but she has the problem and family members reaching out to her in different ways to try to pull her back and restrain her. So relationship questions related to the problem or related to exceptions. I won't be able to go through all this, guys. I'm assuming you guys can look at the slide and read through that, but one of the important questions is right in the middle. What areas of your life has the problem failed to control? And what influence have those areas had on your thoughts and feelings about yourself? And what does it mean about you that you've refused to give in to this problem? And a lot of times I look at questions to try to deconstruct ambivalence. One of the questions that's important here is, what would your body or feelings tell you that would confirm that you were happier? You know, as they're progressing through their unique occurrences and examining unique counts. What does it feel like to be happier? And to think about that, not just in terms of emotions, but in terms of physical sensations. And what is the smallest change that you can consider that will make a difference? And you notice not any of these questions are written in closed-ended fashion. They all begin with what or how or after. The last question is something I ask a lot. After you've been sober for 6 months, 1 year, whatever period of time we're able to look at, and you look at, and as that sober person, you look back at this time, what will you remember that you decided or did that made the most difference? Now, I've had clients who, when I ask that question, they just look at me and they'll say, "That's a stupid question." Okay, but if you could visualize or picture that person that you'll be in 6 months, it's kind of strange. They'll reject the question, but when you come back and say, "But if you could, what will you remember? What will that person remember that they decided to do that made the most difference?" And they'll answer you. It's really kind of strange how that works. Now, if we're applying narrative therapy or any therapy to family therapy, basically there are two essential rules about or goals of family therapy: to help the family talk about difficult things in a respectful manner, and to help the family develop a recovery-focused home environment. That's overly simple, but it's really important. And if you think in terms of structural family therapy for a moment, which isn't narrative, but you can pull some structural concepts into narrative that that basically family structure is composed of roles that family occupies and the rules that govern the patterns of communication. If you change one of them, you're going to change the other. They're recursive, which means they're circular. Um, so Bepko and Creston talked about families in a really helpful way. But chemical dependency disrupts the family. It changes the organization structure. Basically, from a narrative perspective, chemical dependency introduces new patterns and new messages into the family and messages about each person. The family eventually adjusts to these roles and does the best they can to work within what the chemical dependency or the addiction has imposed. Remembering though that treatment completely disrupts the family again. Treatment does the same thing to the family that addiction did in the first place. It disrupts the family, it disorganizes the family, and with time and investment in therapy, the family reorganizes around new rules and roles that are consistent with recovery. This is so important to be respectful of the intrusive element of treatment or the intrusive element of therapy, and to be able to caution ourselves to go slowly and be gentle, as opposed to jumping into a second order intervention right away. Think about successive, gentle first order interventions that build on each other, and eventually they progress. The first order interventions will progress into a second order change. So family sometimes looks like a pie, sort of, where people fit together with their roles and patterns. When addiction occurs, it exists as a new family member essentially, and it changes the shape of each person in the family. So if you take somebody out of that family, the addict out of that family, you start working with them and change their shape or their role and function, so they don't really fit back in that family as long as the addiction is still there in the family, still occupying its role as a family member. So we're really working to help the family move the addiction outside of the family, lock it outside the door, and we think about addressing dilemmas, which Michael White talked about quite a bit. How do you think the problem might want to return? I mean, we do reify the problem in a lot of ways. How do you think the problem might want to return? How much time do you think the problem is willing to wait? Is it patient? In the Alcoholics Anonymous book that alcoholics use, they nickname it the Big Book. It describes addiction as cunning, baffling, and powerful, but it also describes it as patient. If an addict stays sober and they go back to reintroducing alcohol or similar chemicals into their body, they find that they very quickly are using at a higher level than they did when they stopped, because the body becomes progressively more vulnerable to the impact of the chemical, even in the absence of the chemical. So imagine that you found the problem, the addictions journal. What plans has it laid to work its way back into your life? What friends will it send to you? What positive memories will it send to you to soften you up? If the addiction was able to read your life story, what parts of your life story would it highlight in order to plan a return? What would be the first sign that it was trying to work its way back in your life? Once you notice the addiction trying to work its way back in, how will you close the door on it? How will that feel to lock the addiction outside of your house, to lock the addiction outside of your life? Okay. So here's some references, guys. And I am good at talking fast. I'm not very good at talking slowly enough for people to take notes. But I wanted, I think the plan was for us to open this up so that people could ask questions or present a case or do some actual discussion. So I'm going to stop the lecture and just open things back up to you guys.
So although Kim, I think you're running this about now, if you're thinking of cases, especially those of you in internship, and you're thinking, you may have a case that might fit this format, narrative addiction, would you be okay offering it a short description, and maybe Dr. Pate and the rest can use that to understand the application. I mean, Dr. Pate did a lot of great questions and applications, but maybe a more specific case would be helpful.
I see Sophia's hand is up. You can go ahead. You can unmute. Yeah, go ahead.
I was just thinking of a new client. I have only had a couple sessions so far, but